Welcome to the podcast on assessment and management of heart disease related to complex care of the older adult. This podcast was created by Melissa Aslagi at the University of North Carolina at Wilmington. It is based on content authored by Dr. Deborah Chen, Jessica Cabilio, and Dr. Sharon Stephen. It will be presented today in a dialogue with Dr. Teresa Becky. So Dr. Becky, maybe you could just tell us a little bit about yourself before we get started.
I'm a professor at the University of South Florida College of Nursing, and I teach across programs, and I focus specifically on cardiac disease, or all forms of cardiovascular disease.
So the objectives for this module are to begin to prepare baccalaureate nursing students to provide appropriate evidence-based care for older adults with heart disease. Okay, well, why don't you just kind of set the stage then as to what we're going to be talking about with this module.
I'd like to provide some examples of the module content related to knowledge about caring for geriatric or elder patients and how you might gain some additional clinical competence and perhaps passion for caring for older adults with heart disease. So the purpose of these content slides are to offer some suggestions to enhance your geriatric specific learning as an undergraduate student and hopefully in your career thereafter, and to offer some geriatric cardiology content specific to undergraduate nursing. Here are some objectives, and there are others, including identifying modifications that you might make in history taking and physical examination of older adults through the continuum from risk factors such as hypertension to end-stage chronic heart failure. Another might be to develop collaborative plans of care for older adults with heart disease who are at risk for disease progression. You could identify realistic goals and develop plans of care for older adults who have heart disease related to, but not excluding, other things: activity, rest, diet, their medication use, and lifestyle according to clinical practice guidelines. And finally, to co-contribute as an interdisciplinary team member in collaboration with patients to ethical decision-making related to the care of older adults with heart disease. Some of the key points I'm going to cover are these main themes: that critical thinking skills are as essential as the content that you learn, that motivational interviewing techniques promote collaborative care, that teaching in concepts are generally more effective than teaching detailed specific content or learning specific detailed content. I hope to convince you that heart disease kills more Americans than all other diseases combined, but that the face of heart disease is changing. And I hope that using evidence-based interventions for geriatric cardiology patients along the continuum of disease, all the way to palliative care, will improve delivery of appropriate care.
Why is this an important concept for us to consider?
Well, there's a number of reasons, including the fact that the number of persons over 65 is going to increase well over 35% over the next 30 years. So any new baccalaureate students are going to be seeing an aging population. And nearly 2,400 Americans die of cardiovascular disease every day, a death every 37 seconds. And in 2005, which is the most recent statistics we have at the American Heart Association, 1 in 8 death certificates listed heart failure as a cause of death. So more people die of cardiovascular disease than cancers, accidents, and diabetes combined. And while the death rates from cardiovascular disease have come down in the last 2 decades, obesity and diabetes has increased so exponentially that we've really had no net gain. And so we're really going to have to work really hard in our primary and secondary prevention to prevent heart disease. Now, we know what successful aging looks like. We know that women tend to live longer than men, and that those that have more resources through higher education and better incomes are able to take part in healthier diets. They have more access to exercise. They tend to take better care of their risk factors such as blood pressure, smoking or not. And we know that moderate alcohol, that stress management, and good quality of life are all part of successful aging. But you'll notice that many of these risk factors are behavioral and under the control of the individual. So that's an important point to take away from this slide. I like to think of heart disease as a continuum, and I'm only going to use, selected examples here. How hypertension leads to coronary heart disease, leads to heart failure. And we can intervene anywhere along this continuum. And of course, it makes sense that the earlier we intervene, the better the outcomes for patients. So I'm going to talk about some of the statistics that are available on AmericanHeart.org, which is a website that has updated statistics every year. Almost 1 out of 3 adults have high blood pressure, and it's more common in women over the age of 54. And it's much more common among African Americans, although that's not depicted on this slide. And although control of hypertension has improved over the past decade, target blood pressure goals are still often not achieved in the elderly. This graph shows the annual number of adults who are diagnosed with heart attacks by age and by gender. And we certainly see that it is much more common in older age. And for women, they tend to develop heart disease 10 years later than men because they're protected by their endogenous estrogen. That is not the case after menopause. And then here's an example of the prevalence of heart failure by age and sex. And of course, it is much more frequent in the older populations. 75% of heart failure cases have antecedent hypertension. And at age 40, the lifetime risk of developing heart failure for both men and women is 1 in 5. So it is a huge problem, and I'm going to stress again that intervening early is important so that we don't end up with heart failure. So in 2005, again, the latest statistics we have, and the reference is down at the bottom of the slide, 5.3 million Americans have heart failure. And so you are likely to see these in hospitals frequently. Also, we're going to come back to this later, but sudden cardiac death occurs up to 9 times the rate of the general population. And would you know who are at risk for sudden cardiac death? Hospital discharges for heart failure have increased an astronomical amount, 171% since 1980. So this is a huge healthcare burden. We have 1 million discharges now of patients with heart failure. And can you see that for females, the hospitalization rate is a little bit higher? Women have higher hospitalization rates than men, and it could be that there's a number of social factors that influence that. Perhaps they don't have a spouse taking care of them at home, and so they are less able to care for themselves. It might be that it's undiagnosed. There's a number of social factors that might influence this. Now, while we've made great strides in reducing deaths from cardiovascular disease, what's alarming is that the reduction in mortality is far greater in men than it is in women. And there are clearly some gender disparities in heart disease, as well as perhaps effectiveness of treatments by gender that we need to pay attention to. I'm focusing here on coronary heart disease because you can see here that over half of all cardiovascular diseases are coronary heart disease. I also want to bring attention to the fact that heart disease is the #1 killer of women, and women are twice as likely to die of an acute myocardial infarction as are men of the same age. So why is it that that's more than the next 7 causes of death combined, and nearly twice as many as all forms of cancer, including breast cancer? But breast cancer is what women fear more. The symptoms can be different between men and women, and this addresses the atypical nature of coronary heart disease in women. One of the most frequent signs of myocardial ischemia is overwhelming fatigue, and that's a pretty common complaint in many women, so it's often ignored or minimized. So it's really important to know that women don't necessarily have the Hollywood heart attack like men have, or as the media portrays. I mean, there are variances. I mean, there are about 30% of women who do have typical chest pain, but the large majority don't. And certainly diabetic women are even less likely to have central chest pain. We know a lot about what contributes to heart disease. We know there are many genetic determinants. We are aware of environmental factors and exposures, including family history, high blood pressure, high fat, high sodium diet, high cholesterol levels, smoking, obesity, metabolic syndrome and diabetes, physical inactivity, and we know that many psychosocial factors, including depression, are independent risk factors for heart disease. So it's really important to assess all of these. And again, I'm going to point to the fact that many of these are behavioral risk factors that we can control. This slide reemphasizes that. What are the consequences of this burgeoning epidemic of obesity in our country for the development of heart disease? We've clearly gotten heavier over the decade. I really think we need to think about health promotion and risk reduction at all levels of the trajectory of heart disease, from primary to secondary prevention, including reducing traditional risk factors, lifestyle management programs, closely monitoring symptoms, even cardiac rehabilitation. So I'm going to talk about some of the guidelines for these, and this is one of them. This is an evidence-based guideline in the journal Circulation, and it's for cardiovascular disease prevention in women, and a new update will be coming out. But ask yourself how you would respond if a 67-year-old woman with heart disease asked if she should be taking aspirin. What about fish oils? What if she asks about vitamin E? How would you determine how to answer her? And where would you find the evidence? In this document that I've provided, it's a good example of where you might find some of the evidence. Here's one guideline for blood pressure control, that we ought to maintain blood pressure less than 120 over 80 millimeters of mercury, initially through lifestyle modification, weight control, physical activity, alcohol moderation, sodium restriction, and consumption of fruits, vegetables, and low-fat dairy. Another recommendation is that the medication beta blockers should be used indefinitely in all women after a myocardial infarction or a left ventricular dysfunction, unless contraindicated. And you might think about the benefits and risks of beta blockers and the precautions that are needed in elderly patients taking these medications. Here's a set of guidelines for the treatment of hypertension. If you have a patient who says, what should my blood pressure be? Now, you don't want to hand them over these guidelines because they're quite technical, but this is where you'll find the information about what should normal blood pressure be and what are some recommended medications and lifestyle changes for treating high blood pressure. Here's another set of guidelines. If you wanted to know what kind of patients were at risk for sudden cardiac death, this is a relatively recent scientific statement that has come out. I just want to give you a flavor of where you can find these and what a guideline looks like. This slide shows the stages of heart failure, and you could use this to stage your patient's heart failure or present a case study on your patients and classify them according to the stages of heart failure. You'll notice that stage A and B are patients who don't currently have symptoms, so that's a perfect opportunity to intervene on those stages so that we don't let them get to stage D, which is refractory heart failure, which requires specialized invasive interventions. Here's one of the very recent guidelines on the diagnosis and management of heart failure, and these are online as well. It had an algorithm, which I thought was really useful for clearly tracking in a logic model format of what are the kinds of symptoms you see in each of the stages and what are the recommended therapies under each. Now, of course, we would want to individualize them to our particular patients, not only their wishes, but their other comorbidities. But I thought it was a really clear way of looking at the progression of coronary disease to heart failure in one pictorial. One of the important things that this slide demonstrates is within this document was the top 3 reasons patients are rehospitalized for heart failure. One was noncompliance or non-adherence with medical therapy, with sodium and or fluid intake. They were admitted for uncorrected high blood pressure and for concurrent infections, which tipped them over the edge. And again, these are all things that we could try and prevent by talking with patients to see where they might need some assistance and keeping these in check. This would be a great idea for discharge planning and instructions, assessing how they're doing with their own monitoring and seeing where you could help make improvements. Sometimes noncompliance is not the correct word because the therapy has such adverse effects that compliance is extremely difficult in the elderly. So we really need to taper our therapies for what they can manage. I really think it's important to examine our assumptions when caring for patients with heart disease. What are the assumptions that are held about geriatric populations, about geriatric cardiology, about heart disease itself? This lady here has heart disease at a relatively young age. She doesn't look to me to be geriatric. So there are some things that we need to be aware of when we're caring for older adults with heart disease, and one is a really careful assessment. We want you to be aware of why they sought medical care. We want to know what their symptoms are like. You're often asked to assess the patient's and caregiver's ability to identify symptoms. And what do they know about their heart condition and self-care? Because if you don't know what they know, it's very difficult to assess what their needs are. It's important to evaluate their health beliefs and their readiness to change behavior. And how successful have they been in managing their condition before? That will impact how they manage their condition at the current time. Now, I recommend avoiding death by assessment. Rather than sitting in a room and trying to go through an assessment as detailed as you can, a useful strategy is to use a typical day strategy for completing an assessment form. It could be used to ask their recent use of medications or their typical diet. But if you use a tone at a pace and with clarity appropriate in your questioning with a sense of curiosity and really good listening, you're going to develop a better quality communication with the elderly and you're going to get more information. So it's important to fit the assessment into the interview and not the interview into the assessment. And check whether the patient wishes to add anything. Let them tell their story. And then you can go back and fill your assessment form and fill the gaps in. I really think I can't overemphasize the importance of lifestyle modification because heart disease is preventable by 82%. So patients have a lot of control in reducing their risk factors. Some of the things you might focus on is weight reduction because we know a normal body mass index is less than 25. You might talk about the DASH diet, which is an approach to reduce hypertension, and you might talk about sodium restrictions depending on what their level of disease is. You could focus on increased physical activity depending on what their physical capabilities are. And you might focus on limiting alcohol because we know it causes exacerbation of heart failure episodes. Now, I believe that in order to foster and facilitate behavior change, you really need to have the appropriate tools. And so, what I propose and find useful is Jim Prochaska's stages of change, or what's called the trans-theoretical model. And what it does is you can stage patients according to their readiness to change. Pre-contemplation is the stage where patients have no intention of changing, or they're not ready, or they're in denial that they need change. Contemplation means they're thinking about it, they're thinking about change, they're aware of the need to change, but they're ambivalent. Preparation, action, and maintenance require less active involvement or encouragement or motivation because people are really getting ready. What they need in those stages are preparation for relapse prevention so that they don't fall back on old habits, because it's very easy to do. And then I'm going to talk a bit about motivational interviewing, which is a really wonderful way of communicating with the elderly. One of the things that I use when I'm structuring my discharge teaching or patient teaching is I ask patients what they most want to know about. What is the most pressing issue that they're concerned about? While I might think that medications are the most important, a patient might suggest that they would really like assistance with stress management, that is really affecting their lives. And I give you a reference of the authors of this motivational interviewing in healthcare book.
It's also a very nice way to think about partnering with our patients to meet their goals instead of our own. In the Critical Thinking podcast, that's one of the points that is made, is that you need to think through this process from the patient's point of view, and what their goals are, and your plan of care will be much more successful.
Motivational interviewing is very much a client-centered, collaborative model of interacting with patients.
Yes.
For example, your goal might be to make sure that they maintain their cardiac medications because you know that abruptly stopping them could be dangerous. A better, more appropriate tact might be to review their goals in what's called elicit, provide, and elicit format. Elicit what they most would like to know about. Then you might provide them some information and then ask them, what do they make of that? What did they understand of that? Another common thing that happens in healthcare is we have what's called a righting reflex. We want to make everything right. We want to fix patients. And I advise taming that righting reflex, because if you argue too hard for a change, patients are by nature, all of us are by nature, resistant to persuasion. And what you're going to end up getting back is a yes, but. And so I think that if we argue for change, what you get back are equally vocal reasons for why they don't want to change. And because we tend to believe what we hear ourselves say, you don't want them voicing their arguments against change. And I would also suggest that when you elicit argument against change, your patient is telling you to try a different approach. So I want to dispel this myth of an unmotivated patient and rather let patients guide where they want to go and avoid premature closure. We're not going to convince everyone that they need to change behaviors, but whatever motivates people to take steps, even small steps, toward health behaviors.
Dr. Becky, do you have any final words for baccalaureate nursing students who are going to soon be entering practice?
I think some keys are use your critical thinking skills, make sure that you at least consult evidence-based guidelines because they are the best evidence that we have. Stay current on what the latest literature recommends. Listen to your patients. Listen as much as you talk and modify your assessments and your therapies, taking into account that these are elderly patients and may not react the same as the general population. And identify realistic goals and plans of care for elders with heart disease. Become an interdisciplinary team member in their care.
I'd like to thank Dr. Becky for being with us today and for sharing this great information about assessment and management of heart disease in older adults.